and the scientific committee for inviting me to do this. I'm very sorry that I cannot be with you in person, but my wife is very happy since it is my 43rd wedding anniversary today. Just very briefly, a tribute to our Queen, who sadly passed away a couple of weeks ago and whose funeral was last Monday. She had been on the throne for 70 years and had led a life of service and devotion to the country, supporting many medical charities and institutions. A couple of notes on Liverpool. This is a city in the northwest of the country in a very active seaport. It's a historical city. It housed the first tropical school of medicine and also the first public health service in the whole world. We have two very famous Premier League football teams. It is also a city full of culture and music, and it was home to the Beatles. In the top right-hand picture, you can see the Liver buildings and the Cunard building. The Liver building is very famous with the liver birds on top of the towers, and that is my granddaughter in the foreground. Just a couple of personal details. I am a previous council member of the Royal College of Surgeons of England. I continue to assist and be a member of the Quality Assurance Committee, and I'm president of our national association, ENT UK. So aesthetic surgery of the nose. The wider perspective of this includes a lot of things such as skin lesions, skin flaps, reconstruction and septal surgery, but I'm going to limit this talk specifically to Septronoplasty. Now the reason for this is our health system is in a state of change, it's a high degree of uncertainty, and this inevitably will have an effect on training in Septronoplasty. There may well be similar changes occurring outside of the UK, and I thought that this might be of international interest to you all. Firstly, I've looked at the number of Septronoplasties worldwide. Now, the best resource for this was the International Society of Aesthetic Plastic Surgery, and this is considering really the aesthetic Septronoplasties. They did a very large survey of 25,000 surgeons. Not all responded, but they've been able to project some figures from this. And the key findings were that there are no international benchmarks that they can use, but there is a large range in numbers of the Septronoplasty operations according to country. Just within Europe, then many more are done in Germany and Italy than they are in the UK. If we actually look at the chart of the number of rhinoplasties per 100,000 people, then Argentina and Turkey are leading the way by far. The numbers for the UK are probably incorrect because I know that there are a lot more done than are indicated here, and I think that is a feature of the projection of the numbers. If we consider aesthetic rhinoplasty, then this is the 6th most aesthetic, most popular operation for women, but if we consider it over a period of 7 years, then nearly 5,000 were done in 2013, and only 1,330 are being done in 2021. Now, this dramatic change has been attributed to the introduction of dermal fillers. And the women that are undergoing these procedures are doing this in preference to a very expensive but potentially risky operation. Septronoplasty is currently performed by 3 groups of surgeons, usually working independently, but in more complex cases, and certainly in the cleft palate and hair lip patients, they'll often work jointly together. I'm sure you're all very familiar with the definition of functional versus cosmetic rhinoplasty. The functional septronoplasty addressing deformity that affects the nasal airway, and that inevitably includes the nasal septum and deviations of the external nose. Now, it is a group where the patients will often exaggerate the sense of obstruction in order to justify their operation. But it will also include patients who conceal the cosmetic effect of their nasal deformity and often reveal it at the time of surgery or shortly after surgery. Cosmetic rhinoplasty is primarily for nasal and facial aesthetics, and the surgical profile then is focused on the tip and nasal hump removal. It's associated with higher revision rates, it's a little more demanding in terms of patient demand, and it often associated with psychological factors. So septorhinoplasty practice in the UK is currently performed in the National Health Service as well as in the independent private practice sector. The difference is that in the National Health Service, the operations are primarily functional, whereas in the independent sector, it's primarily aesthetic and cosmetic. This creates an interesting dichotomy because our trainees are trained mainly in the NHS and not in the private sector, so that the trainees are exposed only to functional surgery and not to cosmetic surgery. If we look at the system of medical training in the UK, then we have a medical regulator with component parts looking at medical education, professional standards, assessment and accreditation. And following accreditation, the surgeon is then independent to practice as an independent surgeon. So the General Medical Council is our regulator. And the General Medical Council oversees Health Education England and the Royal Colleges. Health Education England oversees all the deaneries which oversee each region in the country. The Royal Colleges look primarily at the surgical standards, the standards of, or professional standards and standards of practice, and also assessment and examinations. This shows the individual bodies, and the map on the right shows the regions within England. Scotland has its own health service, and Wales is also independent in terms of education and organisation of the health education. We have 4 surgical colleges, which include the Irish College, and they all accept the intercollegiate exam. They all contribute to that and to the standards of that exam. The Royal College of Surgeons of England hosts several committees, each concerned with various specialties. So we have 10 specialty advisory committees looking after the 10 specialties in surgery. So the SACs set the surgical curriculum, and they also set the number of operations to be achieved in each domain, be it in nasal surgery or ear surgery or head and neck surgery. all of these things have to be approved by the General Medical Council. So we have a high degree of control in the UK. At the end of training, the trainee, assuming that they have passed all the various sections, including the examinations, they are given a completion of competent training certificate, so known as a CCT. And once they have a CCT, that then allows them independence to progress. So if we consider training in Septronoplasty specifically, then it is listed in the ENT surgical curriculum. It is essential and required that specialist training is provided, and it is inclusive of various techniques that include both open and closed and a wide variety of knowledge. It's accepted that the procedure is challenging and can be difficult, and there are various levels of expertise both in the trainees and in the trainers. And very simply, it goes from a closed approach with an angular deformity that is quite straightforward to address. At the far end of the spectrum, you've then got open approach surgery with a severe saddle deformity, following something like a cocaine vasculitis, as this patient had, and this is using carved costal cartilage as a repair. Several years ago, we had a lot of public alarm and articles in the national press about cosmetic surgery because it was being done by many people who weren't medically qualified, with little control and very little governance. Inevitably, there were many complications and unhappy patients. Our General Medical Council reacted to this, and as an effect of that, the Royal College of Surgeons of England decided that it would create a modular course that would lead to credentialing and a certification for surgeons to prove their expertise in aesthetic surgery. So this has been reasonably successful, and it has now progressed to become an intercollegiate course of all the 4 colleges. However, it is a very high demand on time for the individual surgeon, and that makes it a challenge to do the course, and it's also very expensive, so not quite as popular as the college was hoping. But it is a means of trying to set a surgical standard for aesthetic surgery. So what happened when COVID came and we were hit by the pandemic? Well, we lost all of our operating theatres because they were converted into intensive therapy units, and these were places where the patients with severe chest disease were ventilated. When surgery did start to occur again, it was limited. The number of theatres that were available were very limited, and cancer surgery took priority. So this had a huge impact on elective surgery. We're now in the phase of the recovery plan for the NHS, and surgical procedures that are on the list have all been ranked into priorities 1 to 4. Unfortunately for surgery of the sinuses and nose, they are seen as low priority, and therefore there is some resistance to actually re-operating or starting to operate on this group of patients. But we are starting to recover, and we are getting more numbers through at this late stage. The current situation is that elective surgery is still restricted in many hospitals, and it's largely because although we now have the operating theatres back, we've lost a lot of the staff that we need to support the theatres, and we've lost the infrastructure. If we look at septorhinoplasty numbers in the UK over the last 7 to 8 years, you can see that there is a steady decline, but not great until the COVID pandemic hit, when there was a sudden dramatic fall. And what's happened since is we've had recovery, but only partial recovery. So what about training as a result of COVID? Well, what's happened is that the number of septorhinoplasties is much less, it's much lower, and the training exposure to elective surgery, including septorhinoplasty, is seriously deficient. We've also become aware that there are variations in training across the UK, and that depends on which hospital you're in and which part of the United Kingdom that you're in. To the point where not all trainees are now receiving adequate training. And the required numbers that I mentioned before that were set by the SACs, according to what the GMC was demanding, are no longer being achieved. Now that can have a direct consequence, because it means that the trainees cannot be accredited at the end of their training. Another useful concept, and this chart only came to my knowledge a few days ago and is not in the public domain yet, but this is looking at the number of septorhinoplasties across the whole of the UK in every single hospital. This is from central sources, and you can see that there is a huge disparity. I've marked each of the major training units in yellow, and all of the ones in red are the London teaching hospitals. And you can see very clearly that the London teaching hospitals are actually doing quite a lot more in terms of septorhinoplasty than most of the other hospitals, with University College Hospital at the lead of the game with 2,483. So this has a direct effect on ability to train throughout the country. Interestingly, this has been noticed by our General Medical Council, and I'm now aware that there have been discussions and recent changes which very few people know about as yet. And what they've done is to remove the number of set numbers of septorhinoplasty, so the trainees don't have to record or do a set number of those operations, and the healthcare regions are no longer required to provide training. This change will inevitably reduce the training in septorhinoplasty, and only a small number of trainees will actually gain enough training in this type of surgery. But the good news is that it will not prevent them from becoming independent and from passing their training period. So what are the solutions? Well, these are my own thoughts, having considered the matter deeply, that we should have specialist training centres for septorhinoplasty. So not all training centres should be training in it, and that depends on the expertise of the trainers and the numbers of operations that are being done. We can also develop senior surgical fellowships that are post-CCT. So this is at the end of training, but it's some extra advanced training before becoming a consultant. And these fellowships are currently assessed and monitored by the Royal College of Surgeons, and they are given an accreditation when the fellows get through the fellowship successfully. In addition to that, we should encourage international fellowships and visits to other centres of expertise and excellence throughout the world. So they're my own thoughts, having discussed it with a few knowledgeable colleagues. So what has actually happened? And again, this is not common knowledge in the UK as yet, but our General Medical Council have been in discussion with the Joint Committee of Surgical Training, and their plan is to develop a post-CCT fellowship in aesthetic surgery, which can be accessed from either ENT plastic surgery or oral and maxillofacial surgery. They would ideally like more training in the private sector, but in practical terms that probably won't happen. The control and the governance is not as good and the access is not as good. The other major change that's happening is going from what we call competency training, where you're looking at the basic competence before passing someone in a certain technique or domain, to proficiency training, which is looking at an advanced or an advancement and progress in training. This is so new that I'm going to a forum in 2 weeks' time with the 4 colleges of surgery to discuss this very item. So in conclusion, we have a difficult, challenging operation that requires excellence in training and experience, but the current situation in reality is that there are low surgical numbers with limited access for trainees and limited training. So the future change has to be that we develop specialist training for dedicated trainees who wish to carry this type of surgery out as part of their consultant career in the future. So thank you very much for your attention. I hope you've enjoyed the presentation, and I hope that my thoughts have stimulated you to go a bit further and compare your own country with what we have in the UK. So very many thanks, and come on.